So without further ado, Marlene Benvenuto is a registered nurse with her nursing specialty certification in hospice palliative care, which she's had for several years. Marlene has worked in Thunder Bay in various areas, including long-term care, St. Joseph's Hospital Hospice Unit, and within the Northwest Regional Palliative Care Program. Marlene is currently employed with Home and Community Care Services Northwest as a part-time palliative care educator. So thank you very much for being here to present today, Marlene.
Well, thank you so very much for asking me. I have to apologize for two things. I have pets that may come across. Sometimes the cat just jumps up without any warning. So that's one. And two, bear with me. I'm quite a novice at sharing my screen. So here we go. This will stop others sharing. Okay, I have on my screen. Okay, this will stop others sharing. Do you want to continue? Yes. Okay. Can everybody see that?
Looks good.
So the objectives for today's Lunch and Learn, I'm going to go over some definitions of delirium, dementia, and depression, and showing some of the comparisons, comparing them all in a chart form and what they look like and their risk factors. And at the end of the session, hopefully we'll have time to do a case study, which entails, I'm kind of giving it away, delirium at end of life. So I'm just going to move that over there. Okay. So delirium, dementia, and depression can coexist. It's amazing how many individuals may have a dementia and may suffer from delirium or depression, or someone with depression may experience a delirium. And there are some common features that overlap those symptoms, and that makes it more challenging to determine the correct diagnosis. So with dementia, it's more of a progressive decline in memory, along with those cognition areas such as attention or orientation, judgments, abstract thinking, and sometimes personalities change a little bit. So with dementia, on the average, it's very rare to have someone less than 50 years of age develop it, but I'm not saying that not a possibility. It generally does increase as you age. So these statistics were a few years old. I don't know if they've changed. I have not had opportunity. Increases by 8% for people older than 65. And then again, you see a larger jump with individuals over age of 85 by 30%. Dementia is generally a gradual and progressive disease. It can manifest differently in so many individuals, depending on the disease that is presenting it. When looking at diagnoses, there is not one specific diagnostic test that can be used. It's usually through a form of assessments with, dealing with memory loss, looking at aphasia or language problems, apraxia, those organizational problems, or agnosis.
I grabbed an orange, you guys.
Unable to recognize objects. I think someone's got their mic on. Or unable to recognize objects or say.
No, like literally, I worked from 3 to 7 last night.
Sorry, if people can please make sure their microphones are muted. Thank you. Not you, Marlene.
There we go. Sorry. Through taking a history can be helpful. Physical assessments, cognitive assessments, as well as functional assessments are key in helping diagnosis. Sometimes there may be lab or investigations such as lab work to see about blood levels, CBCs, or the metabolic profiles. If they have a deficiency, perhaps in B12, and there may be head imaging involved. And just realizing that reassessing those treatable disorders. Sometimes there are disorders that are causing symptoms that may mimic dementia, but find out after that they can be treated. As well as looking into comorbidities. Today, a lot of individuals have more than one health issue. So combined, maybe something they need to investigate what is actually the cause. Sorry. So some factors and causes: progression of age, right? Over 65, you may see that progression happening. Vascular risks, hypertension, elevated blood pressures, elevated cholesterol, diabetes, a family history and first-degree relatives is quite, I think, important. Throughout my career, I've observed families where each of the siblings developed dementia, their parents had dementia. So it was a real key factor in providing that health history and family history. Brain injuries or other diseases, right, that may alter someone's thought process along their journey of that disease, as well as smoking, all the hazards that go along with smoking. So our main treatment, because it's not curable, we need to try to preserve the functional status of the individual. And how is that done? We offer support, education to the family, to the client. And I added advanced care planning because I feel that's really important. So when someone is early on in their trajectory of their dementia illness, it's always so important to have those discussions and have the clients be able to have some autonomy when they still have those clear thoughts, to tell their loved ones, give them direction of what would be important when they no longer can speak for themselves. Some other treatments would be non-drug therapies or management, as well as medications you may see. So non-pharmacological and pharmacological, I gotta keep moving my thing over here. So we'll look at non-pharmacological ways of providing treatment. It's, how do I want to say this? Adequate sleeping, good sleeping habits, if we can have that adequate hydration and nutrition. A strict routine in the sense that I believe that people with dementia need a routine. They need to know. They don't do with great deals of change or sudden change. So with a routine, it's more familiar to them. Still including and participating in social activities, and maintaining a proper level of stimuli, right? People need to be stimulated to keep their thoughts going. But in the same token, we have to manage how much stimuli will be helpful, otherwise harmful. Sometimes when people with dementia, too much stimulation or a higher level of stimulation is more, making them feel uncomfortable and maybe becoming agitated, overwhelmed by it all. And that's, I guess, the point I'm trying to make. We have to find that right combination between social activities and managing that stimulation. So pharmacologically, I didn't list all the medications, but there are medications to help with memory and attention. And I just listed the one, Aricept, that's pretty common to my understanding, at least when I was in the long-term care facilities, that was the common medication. And then we have to look at sometimes when behaviors are needing to be dealt with, there are antipsychotics or antidepressants or mood stabilizers that may be added, and that is at the discretion of the physician and the care team. So that's a quick summation of dementia. Then I'm just going to continue on. I know time is of the essence to get through everything, and then you guys can ask questions, looking at what delirium is. And it is sometimes called that acute confusional state. It's generally characterized by that acute onset, those fluctuations in the mood, perhaps even an altered level of consciousness, intentions and disorganized thinking. This is something that starts quickly, may last for a brief time, or may last for a few weeks. And a delirium can also signal like a medical emergency. What comes to mind is perhaps a head injury. You may not think that someone banged their head that traumatically, but now you see changes in their behavior, their consciousness level, is one example. Or a UTI, someone with a urinary tract infection might develop this confusional state. So there are 3 different types of deliriums: hyper, hypo, and the mixed. And I think what really comes to the forefront most people think of is the hyperactive delirium, that heightened arousal where they're restless, they're agitated, delusional, even aggressive at times, where they're wanting to fight, or just persistent that they need to do something, very agitated. Where hypo is kind of like the opposite, more of a sleepiness, quieting of their symptoms, or disinterest in behaviors. Just kind of, I've seen some with a flat affect with their deliriums, or just non-responsive to any, they're awake, but they just don't want to respond to anybody. So totally disinterested. And the mixed delirium is a little bit of both, that alternation between hyperactive and hypoactive. And these types of deliriums, I remember telling you at the beginning, sometimes they have very common symptoms. So think of someone with a dementia that has a sundowning. Throughout the day, they may be very calm, quiet to themselves. And then about 2, 3 in the afternoon, they start to become agitated. They start to pace. They start to, see things just riled up. So this is what mixed delirium is, those periods where they alternate. So you can see that there might be an opportunity to not know whether this is a sundowning with a dementia or a true delirium, or both, depending on, with investigations as to what is found, perhaps with lab values or assessments. But that's just one commonality that I thought was important to bring forth, that you might see in a dementia patient. You might see this delirium and not really know if it's part of their disease process or something new. So some of the causes, electrolytes might be out, just drugs in general, And, as I was mentioning, the example of dementia as well, depression, they can all kind of overlap as to how it is affecting or showing. Dehydration can be a cause. If there's different disease process, perhaps in the lungs, the liver, the heart, the kidneys, or brain, can affect someone and cause a delirium, depending on what the disease process is. I had spoken earlier about like a brain injury or an injury may cause a delirium. Pain, how many people have experienced a very extreme pain and they just can't focus on anything other than the pain, you know, they're very agitated. And even sometimes stress, you can see that happen. People are very stressed, they become very agitated, as well as intracranial pressure. Sometimes medications can cause deliriums. You may be looking at medication errors. You may be looking at omissions. How it is affected their body, how it is absorbed. Looking at metabolic diseases, deficiencies, as I mentioned before, B12. Sometimes people become a little bit foggy and such. Respiratory problems. If someone is not getting as much oxygen with hypoxia, they may develop a delirium, as well as someone closer, say, to end of life, or even a dementia patient, as I was saying before. If they have urinary issues or bowel issues, that agitation may be brought on. I know when I was working in the hospital, one of the first things we check with for a patient with dementia, if there was a change in their behavior, or actually any patient, but mostly with dementia patients, if there was an infection happening somewhere. And first thing we did was urinalysis, just to rule out that there was not a urinary tract infection or pneumonia or sepsis, right? Those things can occur and cause people to have a delirium. Renal failure, we've looked at all the organs and how that can impale on them. Untreated pain or overtreated pain, right? I spoke about medication errors and omissions, or adding too much medication may cause that toxicity. I'm thinking of someone who is taking a large number of opioids for their pain control. Maybe they become toxic from it and they develop a delirium that needs to be addressed. So for the most part, some of the precipitating causes can be reversed. The statistics I found was 40 to 60% of cases are reversible, depending once again upon their illness trajectory. Usually at the end of life delirium is something that I've not really seen resolve. It may diminish, and that's probably with the use of medications and some non-pharmacological interventions as well to help them settle. So how do we, I just have to keep moving this thing around. So how do we assess for delirium? We look using the screening tools, that confusion assessment method, the mini mental state examination, and nursing delirium evaluations. And a history is really important. I know the OPQRSTUV assessment scale is utilized a lot for pain, but it can be also used for other symptoms as well to help you identify perhaps there's an underlying cause, as well as a physical exam to see what a physical assessment to see perhaps if there's something that can be visible or by the exam. Investigations, mostly lab work, urinalysis, like I had said, in some situations an MRI or an X-ray. And once again, that's all dependent upon where the delirium starts in someone's illness trajectory, and why it's so important to address the advanced care planning, reviewing those goals of care to understand what was important to the client. Does the decision maker understand that? The family and the caregivers are aware of what the goals were prior to this, and and looking at how it's to be treated is always important to involve everybody. So management, we have to screen to monitor that, confirm a diagnosis if there is one. Not, I guess, depending if it's a new diagnosis, if it's pertaining to the illness trajectory, it's reconfirming that that's what the cause is, and seeing how we can treat those symptoms. And as well, providing that communication and support and education to the patient, the family, and the caregivers, and how they can participate and help communicate with their loved one, perhaps who at the end of their life delirium can be calmed, or at least attempt to be calming manner to support them. So some non-pharmacological treatments, as I said, a calming environment. The lighting might be dimmer because of their heightened sensitivities in someone who is at an end of life delirium, may need more calming environment. Reorientation, try to redirect them back to reorientate. But I truly believe that in closer to the end of a life delirium, it's not reorientation, it's probably redirection. If they're in a heightened state, redirection is probably a better way to go than the reorientation. A gentle approach, that reassurance, speaking in a calming manner, is really important to not just the clients, but to the family as well, and helping them understand how that technique and what those things can be to achieve that. Avoiding physical restraints. I know in most institutions now no longer have physical restraints, which is a great thing not to have anymore. It only agitates and may trigger, be a trigger for some individuals. So treatments for delirium. So there's the mild, the moderate, and the severe levels of delirium. And we always start with the non-pharmacological interventions first. And if it's necessary, in the mild delirium, we start generally off with a Haldol, or some of the atypical antipsychotics may be used. And that's all dependent on the ordering healthcare provider, if there's a need or how they feel about it. But I've usually seen Haldol and Nozanan very effective. And this is speaking with a delirium for someone who's entering the end of their illness. The moderate delirium, using the same medications, perhaps more frequently or higher doses. We need to control that before it gets into a severe state. And the agitated severe delirium generally is used as PRNs, which is when needed doses. And then once they're calmed, the physicians or the healthcare provider may order a maintenance dose just to maintain them at that level if it looks like it'll be for a while. Usually it's Nozanan at this point. Sometimes Versed or midazolam is used in this situation. And we're speaking at the palliative sedation or the end of life. And those are only used for exceptional cases when the delirium is refractory, which means it's not very well maintained. And that is used following a discussion with the family and the healthcare team as to goals of care and what the intent. So we'll look now briefly at depression. So with depression, you'll see low moods or loss of interests in activities, and difficulty with sleep, appetite, concentrations, that feeling of worthlessness, their motor abilities may slow, may be restless, as well as sleep. They may sleep lots, they may not sleep. They may eat lots, they may not have an appetite. With depression, though, it lasts greater than 2 weeks, and it does affect them socially and occupationally functioning. I believe because they usually go within drawn and perhaps don't want to interact with people, and maybe missing time at work, or not doing their own care that they need to provide for themselves. Just realize that depression is not a part of normal aging. Unfortunately, depression has the highest rate of suicide, and it seems to worsen symptoms of other illnesses, especially a cardiac disease. And depression can cause what we call a pseudo dementia. And that's a condition where the mental cognition can be temporarily decreased. And one thing about depression, it may last for months to years, but the good news is 80% of that is treatable. And once people are treated with whatever forms that they need to their depression to be relieved, is workable. So treatments, basically through primary care physicians, mental health specialists, psychotherapy, sometimes medications, ECT therapy, the electroconvulsive therapy, or other modalities. I know of people that have suffered from depression, do acupuncture or do some sort of meditation. So whatever works, what might work for one might not work for another, or they all maybe all needed. So here I've included a table of all the characteristics, and I'm more of a visual person, so you can see all the differences in each of the Ds: depression, the longevity, the onset, delirium, the onset, and the dementia, how they vary. But as you go down, you can see that the mood for delirium and dementia fluctuate, like the example I had given you with the sundowning and the delirium that may be hyperactive or mixed, where a little bit of the hypo and the hyperactive episodes. Courses, chronic, but it can respond to treatment. Acute can respond to treatment, but dementia is more of a chronic and deteriorates over time. Self-awareness, maybe likely concerned more about their memory impairment, where in delirium and dementia, you'll see those cognition changes, where a delirium, it fluctuates. Dementia, the patient may likely hide some of the cognition deficits, or not even be aware of those deficits. As well as with activities of daily living, someone with depression may neglect their basic self-care, where delirium as well as dementia, you'll see that it may be intact early and then may be impaired, and with dementia be impaired as the disease progresses, as well as with the instrumental activities. So does anybody have any questions before we start the case study, or shall we just go right into the case study? What are your thoughts?
Don't have any questions in the chat right now, but if anyone, oh, Kevin has a question. Go ahead, Kevin.
Hi, Marlene.
Hi.
Have you witnessed Have you witnessed any delirium following someone dealing with COVID? We've had a couple of people in our circle of influence here who have had 5 or 6 days of being COVID positive. And then as they're kind of coming out of the COVID situation, they wind up with symptoms of delirium anywhere from a month to 2 months.
Professionally, I can't, but I can speak to you personally. My husband and I both had COVID in October, and both myself and my husband did have like a foggy brain, and it wouldn't happen all the time, where the concentration was really quite limited, like to follow instructions was challenging for myself, but it dissipated. But it would kind of happen for a few days, and they would dissipate, and then would just gradually decline. Like a few days later, be for a briefer time than the time before. So does that help? You know, I know I'm conveying something personal, but I just thought that may be helpful in understanding. But professionally, caring for other individuals, no, I have not.
We've definitely seen our share of it. We've had half a dozen different clients who have coming out of COVID anywhere from 1 to 2 months, have had sometimes sundowning symptoms, and then we were thinking, wow, this dementia's come on quickly, and we interpreted it as delirium because it has not progressed after a certain time. But it was a month to 2, and certainly delirium type symptoms. I just was curious whether you'd come across it as well.
I can't say for 100%, but articles that I've read and observed indicate that if there is some dementia, that it might could enhance it for a briefer time. That's just what I've read. I cannot say 100% that that's clinically fact, but the articles I read on the government pages had indicated things of that nature.
Thank you, Marlene.
No other questions or comments? We can head to the case study if you like. So this is more pertaining to a delirium at the end of a life trajectory. So Christine is a 79-year-old female diagnosed about 1.5 years ago of squamous cell carcinoma of the mouth. She underwent extensive surgery, chemotherapy, and radiation therapy. Unfortunately, the cancer has continued to progress with metastases to her lung and her liver. She is being cared for her husband, Jim, of 50 years, who suffers from several health issues himself. She is a mother of 1 and a grandmother of 3 who lives in another province and has become estranged, and she now has daily services. Oops, sorry. So her husband has indicated 2 days ago that Christine has become restless during the evening and not sleeping at night, and stated his wife was talking to a relative who had died several years ago. Christine has not been eating or drinking much lately and complaining of being more uncomfortable. Her husband indicated that he had been giving her extra doses of her pain medication to help her with her discomfort, but she continues to moan. Jim has called the community nursing agency to come and assess her. Her PPS, which is her palliative performance scale, which is a functional scale, now has changed from 50% to 30%. What is happening? What additional information do we need? And what needs to be done at this time? Anybody like to venture into answering any of those questions?
I would be interested in knowing the increased medication. What is happening there? What was the medication and how much was it increased by?
Good question, right? And well, I don't know if it was increased, but he gave her extra doses. So how many PRNs or how many, when necessary, pain medications did he give has not really been indicated. Extra doses, yeah, could mean 2, could be 4 in that 24-hour period, right? But thank you. That's a good question to ask. What do you think is happening to her? I know at the beginning of the presentation, I kind of gave it away by saying delirium case study. So I guess this is a redundant question to ask you. What do you think is happening? Do you think this is a reversible delirium? Or do you think this is more of an end of life delirium? Anybody care to
We're getting a
comment?
few comments in the chat as well here.
Okay.
Kevin had said he would encourage a check for a UTI.
Right.
And Barbara is saying possible dehydration, constipation, lack of nutrition. And then someone else saying end of life delirium.
Yeah, and those are all good answers because we'd have to investigate all of those, right? But looking at her illness and you know, the advancement of her illness could possibly mean end of life delirium. One question or one comment, it's not indicating that it is possibly involving the medications per se. Now I'll be the devil's advocate. He's not commenting about any monoclonic jerking, you know, as to indicate if she's too much of the medication. Maybe he's misinterpreting the pain. The moans could be part of the delirium. Doesn't state how unresponsive she is at this moment. But yes, we could check to see where if there is a pain or he feels it is pain, knowing that he knows his wife. Maybe has she voided? Has she not moved her bowels? Those are good comments. What type of investigations, if any, would you suggest be done? Someone had commented maybe they were suffering from constipation, perhaps a physical assessment to see if those were the issues. Yes, urinalysis, blood work, right? Maybe urinary retention if quite a few doses of medications have been given, right? We all know that opioids can cause urinary retention. Last one. Perhaps a reaction to chemo could have been caused. It doesn't really indicate how long ago the surgeries were or how long ago the chemo was, but that could be a possibility. I'm wondering, this is post perhaps a while back and now it's progressing. And looking at her palliative performance scale, her functional abilities, now she is 30%. Usually on a palliative performance scale trajectory, 30% and less is more of an end of life journey. I guess I should go on and explain for those who are not aware of what PPS is. It's just a form of assessment, and all of us are pretty much 100% because we're able to walk around, we're able to feed ourselves. It has 5 different categories, and that's just a quick assessment guide. So generally, someone at 50% is slowing down and, you know, journeying towards the end of their life, perhaps, and 30% is definite. signifying, especially if she'd been up prior to this. Exactly. Sarah had commented, wanting to repeat the PPS after some interventions. Oh, thank you, Olga, for posting that. The palliative performance scale, Olga has been so kind enough to put that in the chat, the website to look at it for those who are not familiar with it.
I
Perhaps
see I see. Oh, Kevin, did you have a question? I just saw your hand was raised and.
Sarah made the point. I was just going to say that with the types of cancer that she has and the way her body's been devastated, that could be an infection other than a UTI. It's amazing what an infection in the body and the body fighting infection can do. It's extraordinary how it can affect our cognitive abilities and even our desire to eat. So it seems to me as though what needs to happen at this point is someone needs to ask 100 or so questions and literally kind of drill down. And when the husband says, "Oh, I've increased her dosage," well, we have no idea how much he gave her.
exactly.
You know, or how much she's drinking. So if there's home care, sit with the home care team and say, "Guys, okay, we're going to record liquid volume in, we're going to record liquid volume out, we're going to gather some data."
In some situations, doctors will try the hypodermoclysis, that hydration in the subcutaneous tissue of the body. If, say, IVs are not accessible in the veins, to see if that will rectify some of the delirium, those simpler tasks to see if that is helpful. And once again, I believe it was Sarah had indicated, correct me if I'm wrong, reassessment after each intervention, right? And we'll be monitoring daily. And once again, understanding the disease process, have those discussions about what has been discussed, what has Christine identified as important to her if cure is not possible, and what her journey would look like and what she would hope she would receive or hope it would be like along the journey to the end of her life as well. So not to say that those hopes and those goals may not change along the journey, but it's always good to kind of ask, what would Christine want if this wasn't going to be reversible, the delirium, or if these interventions, so those are all good suggestions.
Marlene,
Yes.
I just wanted to interject. I am loving the level of participation and interaction with the case study. We are getting really close to time, though. We were scheduled till 12:45, so I do understand if people need to step out. And again, we will share the recording afterwards. But Marlene, if you're willing to stay a few more minutes and
Sure. Sure. Well, thank you everybody for your participation in the case study. I was anticipating crickets, so thank you for all the inputs. I hope you found this presentation somewhat helpful in understanding the differences and how they can overlap with each other, and we need to be able to identify those things. I have one more slide, and this is, regardless if it's dementia, delirium, or depression, each older adult is unique, and being with their own life experiences, their strengths, their preferences, and cultural practices, values, and beliefs, who deserve to be treated with dignity throughout their entire journeys, whatever those journeys may be. So thank you very much for attending today.
And I'd just like to thank you very much, Marlene, for taking the time to be with us and present today. That was a great case study, and we definitely could have used some more time. So thank you all for your participation as well. And just to let you all know that our next Lunch and Learn will be on February 15th, and it will be on the role of the Retirement Homes Regulatory Authority, presented by Kaisa Metcalf, who is an RPN Partnership and Engagement Specialist, and we will have that posted soon on our Sarah events page, which I'm going to put the link to in the chat. And yes, thank you all again once again for joining us, and I hope you all have a great afternoon.